Okay, so welcome back again to Montreal Heart Institute. I'm Jean-François Tanguay. I have the pleasure to work with Dr. Guillaume Marquis-Gravel.
Hi, everyone.
And Dr. Theophilos Panagiotis that you saw in the previous case a few weeks ago. We have, I think, an entrance case to discuss with you today of stable coronary artery disease, but multivessel in a 60-year-old man. Okay, so again, what we would like to discuss as teaching objective is also the role of imaging versus physiology, or maybe sometimes both in some specific cases. Next one. Again, this 60-year-old gentleman was referred from another center for stable angina, de novo stable angina. He had no previous history of coronary artery disease, was treated with for new dyslipidemia and hypertension, and he had no history of diabetes mellitus. He had a positive stress test, quite severe positive stress test at the other center, and was sent to us for coronary angiography. Next slide. Again, we'll show you in a few seconds, but it was multivessel, so quite a surprise to him. Proximal lesion, the Medina 010, a mid lesion that was 50 to 70%, and a distal lesion that was quite severe at 70 to 90%. The circumflex had also proximal lesion that was 70%, OM1 as well. And the RC had, again, a multi-site lesion. Proximal LAD, middle LAD, and then a distal LAD.
Okay, 15-25 si on veut.
With bifurcation of diagonal, but they're not, they don't appear to be a disease at this time. So next one. So we see again the lesion on the left system, the circumflex that's quite severe also. And next one, please. So the spider also. So we discuss again the plan, but the right had disease in the proximal part, the mid part. I have to work on that, and distal intermediate. So we'll see. You can see the collateral to the left, suggesting that the lesions on the LAD are quite severe. So we don't need probably physiology for the left. We were planning more imaging to kind of look at the landing zone of the stent and the proximal LAD with the left main. And the goal was today to illustrate the LAD first, multi-site lesion. And there's calcium. We'll show you in the IVUS in a few seconds.
Test.
The next lesion we'll do will be the right, and then use physiology with co-registration to demonstrate which lesion, again, we haven't done it, which lesion are significant that require to have a stent. So that will be the co-registration with the Philips system. Could we go back to the PowerPoint slide, please? Okay, so that's I showed you the angiogram. We are planning to start with the LAD first, probably 3 stents.
And cross.
Probably we will avoid the left main from what we see angiographically, and we will show you the IVUS, and then the circumflex, and then in a second attempt, do the right after that. Next slide. So again, for this case last week, we first discussed with the patient the potential for bypass because he had quite important disease. He's 60-year-old, but he has no diabetes, and the LV function is normal, ejection fraction of 60%. So the two options are a good option, but we had to understand the risk benefit. So we just did a diagnostic, brought him back to the floor. The surgeon saw him, we discussed, but the patient at 2 times refused to have the surgery performed. He really wanted to have the percutaneous solution, which we said is doable with an increased risk maybe of restenosis and recurrent angioplasty, and always the other option of at some point going to surgery in the future. So today we asked him again if he wanted to have no surgery, and he refused. So we went to consent him for the angioplasty today.
So where we started middle AD, as you can see, there's a 360 arc of calcium, severely calcified.
You can see the calcium there. Yeah.
Yeah. And as we do the pullback, calcification remains severe. At some point we come in a normal vessel for just a little bit, and then come back to the calcified. The question we had looking at the angio is where will be the landing zone in the proximal LAD, right? From the angio, it looked like we would need to stand flush before the left main in the proximal LAD. So we wanted to use IVUS to decide whether or not we should go to the left main or not. It's very hard from the IVUS images here to decipher where does the left main starts and where does the LAD ends up. So we're gonna do some orbital atherectomy and see how it looks like, and then decide where the landing zone is going to be.
Yeah,
what do you think, JF, about the landing zone for
I
the
think so.
proximal LAD?
Again, I was busy setting up, but at the same time, I think from the angiogram and now the IVUS is maybe unclear, but we'll do it after the orbital atherectomy to find out. I thought there was a good landing zone in the ostial proximal LAD without going to the left main. But we'll see with the IVUS. So we're working live now.
Okay. So we're about to start the orbital atherectomy. So we use orbital atherectomy or rotational atherectomy here at the Montreal Heart. We think both strategies are much useful. Here we have a lesion with a very circumferential calcification. So we thought that orbital would be maybe the way to go. Obviously, we don't have randomized trials comparing rotablation versus orbital, so we don't know. But in theory, at least, if we have circumferential calcification, orbital atherectomy makes sure that we ablate most of the arc of calcium. Other considerations for using orbital atherectomy is that it addresses deep calcium. Here, we don't know because we used IVUS. We didn't use OCT, so IVUS is not the best strategy to evaluate for deep calcifications, but unfortunately we had technical problems preventing us from using OCT here. So we're using IVUS. We know that there is a superficial calcification here, but we don't know about deep calcifications.
Good, thank you. So I agree with you. So we'll start going the orbital atherectomy if you're ready.
Yeah, is everyone ready for orbital? Is it on? So we're going with low speed here. Important to go 1 millimeter by second going forward. I don't know if you can hear it here, but the sound is very high frequency. So we're in something, we're in a lesion. One good thing with orbital atherectomy is that we can ablate forward and backwards. Here we go. Gonna let the artery breathe a little bit. The risk of crown entrapment is much lower than with burn entrapment with rotablation, so that's a good thing here. I think we're going to need to do a lot of passages of the crown because from the onset in the proximal LAD, I think I would do a couple of rounds again because still it was high pitch when I was doing it, so there's still some more work to do, I think.
We'll do a bit
and we'll try to minimize the contrast, even if the patient has normal renal function at baseline.
Yeah, he has a normal renal function, normal hemoglobin. Yeah, for the other, there's no significant disease except the cholesterol, hypertension. All the rest are okay.
So one of the challenges here that we haven't foreseen, we are going radial. We are using a 6 French guiding catheter, XB35. We don't have the support we wish we would have here. So the catheter keeps on going in and out. Going to need to be very careful while doing the orbital atherectomy. Here it's very tight here.
Resistance a bit there.
What?
You have a bit of resistance, or is it you feel?
I feel some resistance, and still very high pitch sound, suggesting that we are in a tight lesion. Here we go. It jumped. But that's a good sign. That means that we work properly. So I feel pretty confident here that we've done a good job. There's way less resistance than there used to be at the beginning. I'm going a little bit too fast here for the orbital. So remember, orbital atherectomy, if we want to ablate properly, we need to go 1 millimeter per second, not more than that. Otherwise, we're going to miss some calcific spots. Okay. All right. Okay. Sounds good. So we're going to remove the crown. Go. All right. Can you do a small test?
No.
Just
You would need to move the camera to your hands, but I'm not sure.
what do you mean?
You want to see?
No, just do a small test.
Oh, yeah,
Yeah,
sure.
what we get. Yeah.
Okay, go.
Here we go. It looks good. There's no perforation. So let's.
We need to go distal, or for now we've used balloon to open a bit at the beginning.
Yeah, we opened with the balloon. We didn't go with the IVUS down there because
Yeah,
just we had a support issue.
Yeah.
We really wanted to go with the IVUS there. We pre-dilated the distal lesion with a 2O balloon. But we were not able to deliver the IVUS catheter. So I think it's a distal lesion. What do you think? Do you think we should ablate it as well?
I wonder if we could not just ablate it before putting the stent, maybe reduce the risk of losing the diagonal. I think you have more experience with the orbital atherectomy, but
we're having some support issue here with the XB35.
Sure.
It's going to be difficult.
Okay, so then we go
to
with
bring the crown here, unfortunately. So I think we have other options, right?
Yeah.
So if we need to do atherectomy, we can use cutting balloons and so on.
Yeah. We
still have lithotripsy that we use a lot here. So, obviously with orbital atherectomy, we crack the calcium, we ablate it, and we crack it as well. So, even if we still see some calcification on the angio, some of it is cracked, and it's easier to expand the balloons and the stents afterwards. It's
going to be better. Better to prepare than just put the stent, and after that, you have under expansion of the stent. Yeah. So I think that's a good idea.
I think that's a question for the. Oh, how does the efficiency of orbital atherectomy compare to that of balloon angioplasty? That's a good question. So we need a randomized trial to answer that question, right? And we don't have any so far. The Eclipse trial, I think it's close to be completed or already completed. So we need to have some randomized data.
That's for sure. At the same time, the art of angioplasty, sometimes we do things without the data. But I agree that they may not be the most scientific way of doing things, but that's part of our history to innovate and then to gather data and then to adopt. So I agree. I mean, we could have tried balloon first. We could have tried cutting balloon. We could have tried we chose the orbital because it could also go more in size at some point, go back and forth. I mean, Guillaume, I think we discussed that.
Yeah, we can go back and forth. And the other thing with orbital is that we don't. It's one size fits all, right? We don't have to switch burr.
Exactly.
With rotational atherectomy, we need to switch burrs. Orbital atherectomy just adapts to the size of the vessel, so it's one size fits all. And the other thing is that we don't want to have what we call orbital regret or rota regret. That means that if we try with the balloon and it doesn't work, and then we cause a dissection, then we're stuck, right? Orbital atherectomy and rotational atherectomy are in theory contraindicated if there's a dissection. So if we think that it's very calcified and that with balloon it's not going to work, or we're going to have a suboptimal result, there's no randomized data to tell us the answer. But experience says that we don't want to have rota regret, and this is why we used it on that case.
Again, like I say, we have a plan when we begin the case, but we have to adapt to whatever situation we have. And that's what we're doing now. I mean, it's not a complication. It's just that, it's resistant or recoil, and the balloon was not fully expanded.
Right.
And if we go with a bigger balloon, well, the risk is having a dissection and occluding the diagonal. So I prefer to be safe. Like I said before, go in the diagonal, protect it.
Yeah.
Then probably use shockwave in that resistant lesion. And then we stent it and we see if we have to do what type of stent strategy.
Yep.
But initially it was a provisional one stent in that distal lesion.
So I don't know if you can see it, but basically the shockwave balloon here, it basically looks like a normal balloon with just a little bit
with larger profile.
A larger profile, right?
Yeah. I mean, I think
there we go.
In some way, it changed a bit our approach to some calcified lesion when it's deep calcium.
Yeah. So we're just going to inflate here, and as we're inflated, you can pull on the balloon to engage properly. Okay.
Yeah.
So we go to 6 atmospheres.
Usually I go 4, 6, whatever, low pressure.
Yeah.
And then sometimes you see when you start a little, the balloon could open even bigger, but you see now it's good.
Okay. Do the first round of shockwave. So
So you don't hear much, but you have the shock wave.
Yeah.
I usually do several. Even
Yeah. Can do 8 rounds of 10
cycle, whatever.
10 cycles, right? With one balloon. Afterwards, you cannot use it anymore.
Okay, you're off now.
Yeah.
We can do another one. And
yeah, on. So here's going to be a bit boring because we're going to do this procedure. So I'm at 8 atmospheres now. He was going to do the shock wave. We're going to do that, 4 or 5 times?
Yeah, exactly. While we're there, at some point to make sure we have an influence the most we can on the the vessel, and then after that, I think either we decide to stent or we go with IVUS. But I think for sake of time, also, if we see the result is good, I mean, it would go stent.
So for size-wise, the distal reference diameter. Again, we would have liked to have the IVUS here, but I think. What do you think? I think with a 3.0.
Distal, maybe I would start at 2.75 and then post dilate with a pot. That's why we have to have the length of the stent long enough to be able to pot.
Yeah, so we need to be at least 6-8 millimeters approximately to diagonal to pot.
I agree completely, and depending on how short the balloon we have, and then distal, you see if it's guiding is 6 French 2 millimeter. Can do the IVUS, but it looks like 2.5 maybe, maybe 2.75. I think 2.75.
Okay, 2.75, fair enough. And for the length,
at least
let's say 23, just to make sure.
Yeah, but, was going to be my suggestion to make sure we cover the distal lesion and then go back to be able to do a putt.
Okay, so let's take 2.75 23 stent. Okay, so we have the stent here. You go. So clearly here we have a complex PCI according to, there was a lot of criteria for that duration.
Yes.
I mean, a lot of criteria to define a complex PCI. I like.
Okay. Are you negative on this, or you could put neutral sometime? Neutral helps. I feel that, again, it's not a long balloon, but the non-compliant, when you put negative, becomes really very stiff. If you put them neutral, at some point, I felt that sometimes they can make a difference to deliver. I'm not sure in this case, but sometimes I do that. Okay, maybe it's not going.
Let me try.
It's a short one. Yeah, try and leave it neutral. The wire were not crossed, Theo, obviously. That's another thing. I'm very careful when I just do 180 degree, not to, how can I say, loop my wires.
So, here, unfortunately, the diagonal wire came out a little bit, and it's not possible to
leave it there, maybe.
Yeah. It's not possible to push it back because it's behind the struts, right? We're a bit stuck.
No, leave it there. I think I will leave it there.
At least we're going to have a visual marker if we need to go back there.
Exactly. And if it doesn't go, then we could try to remove that wire, recross, or bring another wire into the. You see, good.
Here we go.
Okay, let me see now.
Okay, test here.
Okay, I can test. Be a bit too far.
Yeah, here. Okay.
Okay, ready?
Yeah. Go.
So again, you're right, Guillaume. The wire gives you a landmark.
Yeah.
I really try to be careful not to go
20
distal, and it's a trio, so we can go up. This should open the stand, open the struts to access the diagonal if we need. And usually, I like to do a little mini kissing, not to dissect whatever the diagonal, to keep it simple. But I think it may be useful to bring another wire and go in the diagonal. But we'll see the result.
Okay, so again, this is really not ideal, opening.
You want to open something up there or no?
I don't think so. I think we're okay. It's not ideal open or doing the pot on the radio opaque part of the diagonal wire.
No.
This is not what we should do usually. But here we're kind of stuck. So okay, let's do a cine.
Yeah, cine, ready. Watch, the wire is still advanced.
Very nice. Okay, the diagonal
That's
looks
good,
good.
you know?
The
Yeah.
result here is good.